My name is Judit Karacsonyi. I'm from Hungary. This case was done in Szeged, in the University of Szeged. I used to be working as a research fellow with Dr. Balakis before that. So thank you for the opportunity to present this case. So our patient is a 50-year-old woman who presented with a stable angina and dyspnea on exertion. She has the usual risk factors: history of hypertension, obesity, hyperlipidemia, and diabetes. She had a reduced ejection fraction on echocardiography with akinetic inferior wall, akinetic apical segment, and hypokinetic posterior wall. We performed a cardiac MRI, and the RCA territory was viable. She presented for a coronary angiography in another hospital, which found an LAD, significant lesion, and the right coronary artery CTO. So in this other hospital, the LAD PCI was performed 3 months prior to our procedure with one drug-eluting stent. The size was 2.75 by 24 millimeters. So here is the dual angiography of the procedure. We can see the right coronary artery CTO. We can see that the stump is blunt, and there is a side bench at the proximal cap. The lesion is approximately 30 millimeters long. There is a nice landing zone at the distal part of the vessel, and there are nice collaterals from the septal and as well as the epicardial ones. From another view, we can see the nice septal collaterals coming from the LAD. So just to summarize again, the proximal cap was blunt. The lesion length was approximately 30 millimeters. We had a nice landing zone and nice septal and epicardial collaterals. So based on this, we decided to first go with the antegrade crossing strategy, and then if it's not successful, switch to retrograde, and after that ADR. We follow the hybrid CTO algorithm in our cath lab mainly. So first we decided to put a BMW wire in the side branch, and then we went with Gaia second and with a fine cross microcatheter, and it showed quite a nice progression of the wire, but as we proceeded further, the Gaia second went subintimally. We confirmed this with the contralateral injections from the left system. So then we decided to switch to the retrograde crossing strategy, and we picked nice septal collateral coming from the previous LAD stent. We could go through with the Sion guide wire through the septal collaterals, but the microcatheter wouldn't follow. So then we decided to dilate the ostium of the septal collateral, and this was in the previous stent. And after this, we could pass the fine cross microcatheter through the septal collaterals. So we reached all the way to the distal cap, and we tried to cross the lesion with different guide wires. It was quite a long manipulation at this time. We could pass the microcatheter all the way up to the distal cap, but suddenly the patient reported severe chest pain. ST elevation appeared on the monitor, and then we did a control angio of the left system, which showed a thrombus in the left main. We immediately did a thrombus aspiration. After that, the patient became a little better, but the next angio showed that there was no circumflex, so probably the thrombus embolized to the circumflex. So quick rewiring of the circumflex and again thrombus aspiration. When this happened, the ACT was 303 seconds. In our procedures, our protocol is that we check the ACT every 20 minutes during the procedure. So then on the next angio, from a different angle, we saw that there is a thrombus in the previously deployed LAD stent. So we did thrombus aspiration again. We can see that the thrombus over there. And we decided to post-dilate the previous stent with a 3.0 by 15 millimeter non-compliant balloon. At this point, the patient finally became hemodynamically stable, and the chest pain resolved. So after that, we continued with the retrograde procedures, but a next problem happened. The Sion guide wire broke, so we had to remove this broken guide wire with trapping with a balloon. But during this manipulations, we had to give up the retrograde setting. So then we switched back to antegrade again. And with the Gaia wire, we could pass to the true lumen, and we confirmed this with a microinjection from the fine cross microcatheter. After that, we tried to switch the wire and then try to pass balloons to predilate the lesion. But the balloons wouldn't cross, so during this manipulation, we lost the guide wire position, and then we had to switch the guide and then again try to rewire the lesion. We tried several wires, including the pilot 50, but it didn't find the true lumen, and we went subintimally. So at this point, we decided to implant a 3.0 by 30 millimeter drug-eluting stent in the proximal RCA in order to keep the vessel open for a possible second attempt, but we gave up this attempt. So this was 540 milliliters of contrast, and the procedure time was 3:07 minutes. So 2 months later, the patient presented again, and her angina didn't improve. She still had very severe symptoms, so we decided to go for a second attempt. The lesion looks same like in the control NGO of the last procedure. So this time we went straight retrograde. We picked a more distal septal collateral, and we used the cyan guide wire again with the fine cross microcatheter, and we could reach successfully the PD branch and after the distal clap. And after that we could cross with the retrograde cyan guide wire to the acute marginal, to the RV branch. And then we tried to rewire, and after a reverse cart, we could successfully cross the lesion. So then we externalized the wire with an RG3 guide wire, and then we did predilation of the lesion with kissing balloons. And we could see that there was a subintimal retrograde crossing proximal to the RV branch, so we faced another problem again, how to restore the bifurcation. So we decided to because the branch was quite big, we decided to go with 2 stent techniques, namely with the crest stenting. So we did the crest stenting with a 225 by 38 millimeters DES and the 2.5 14 millimeter DES in the side branch. And during these manipulations, again, the patient started to have chest pain, ST elevations on the ECG. So we did the control NG of the left SIF stent, and we could see, again, thrombus formation in the previous LAD stent as well as the left main. So we decided to do, again, thrombus aspiration, and we implanted a 2.5 by 22 millimeter DES to the LAD. At this time, the ACT was, again, normal to 350 seconds. So after stenting of the LAD, this was the final result of the left system. And this is the right. So all in all, we used 350 milliliters of contrast. The procedure time was 290 minutes. Fluoroscopy time was 64 minutes, and for a little more than 4 grays. So to conclude, investment procedures are important in CTO PCI. We have to be careful with the potentially malapose stents in the donor vessel. Collateral crossing through previous stents can be quite challenging. Distal reentry in a bifurcation can be solved with the crest stenting, as we saw in our example, and don't give up even if a complication happens. Thank you for your attention.
That's great. Quick question. So from the anticoagulation standpoint, both procedures were done with unfractionated heparin?
Yes, we use heparin in our procedures, and as I mentioned, we check the ACT every 20 minutes, and it was normal throughout the whole procedure.
So I think, you know, it's extremely unusual, but I would say if you have thrombus formation on unfractionated heparin, then I would probably try to change the strategy for the second go-around. So either direct thrombin inhibitor or consider some supplementation with intravenous P2Y12 or maybe even 2B3A for that matter. But obviously something's not working with unfractionated heparin.
Yeah, I had 2 questions about that. What was your goal for ACT while you're retrograde?
It's over 290, 300 in retrograde.
Yeah, because typically for retrograde, we'll shoot for over 350. So we're in, you know, we're basically above detectable range for the most part for that very reason. So we tell our nursing staff in case we're distracted, because there's a lot happening during a retrograde case sometimes, that like we're going retrograde now, so they know to keep the ACT high, and they'll keep bugging us for it to make sure that we adhere to that, because obviously the donor vessel thrombosis can be such a big, difficult to manage complication, which you guys did very smoothly. Also, just wondering, especially the second time when your ACT was 350, and of course it could be somewhat spurious, but if there was any imaging of that other stent available, just to make sure that there wasn't something going on there in the LAD.
To tell the truth, due to the hemodynamic instability, that's why we didn't perform IVUS, because the patient was feeling very unwell, and we decided not to waste time with the imaging, but like immediately implant a stent. After that, it could have been done. You're right.
Idea.
Thank you.
Yeah, I would definitely check your calibration of all your equipment because this is very unusual, of course, that you would have that. And obviously, you know, we go for 350, or at least a 300, maybe 350 for the donor vessel because donor vessel is a small one, you know,
Yes.
not in the left main, right? Something happened. I mean, you think it maybe was a embolism from poor flushing technique or something, but to happen twice implies there's something wrong with this patient. I mean, so I agree with Dimitri completely. You need to supplement here, even though we say don't use bivalve for CTOs. In this case, you might want to use bivalve, or you don't use glycoprotein inhibitors because of risk of perforation. But you know, maybe in this case, you know, preload, of course, preload with ticagrelor or prasugrel. So I mean, if you've done all those things and this is happening, I think, you know, he's just warning you that he might have something going on.
Yes.
HIT, or especially HIT, would be of concern.
Yes, thank you. To tell the truth, after the first procedure, we didn't think that it could happen again. So, you know, that's why we didn't like switch the anticoagulation. And
Yeah.
but thank you.